I'm Ruth Dobson. I'm a clinical senior lecturer and neurologist based at Queen Mary and Barts in London.
Does MS affect my chance of conceiving?
So as far as we know, MS doesn't affect your chance of conceiving. It's actually quite hard to know this for sure, and the reason is that we don't really know how many people in the UK at any one time are trying to conceive, and we don't know how many people with MS are trying to conceive. So the information's really not out there, but based on what we have got, there doesn't seem to be a significantly lower conception rate in MS, or importantly, a significantly higher miscarriage rate in MS either.
And if someone with MS did have children, are they more at risk of getting MS?
The risk of someone getting MS is higher if they've got relatives with MS than if they don't. So yeah, the risk of children of people with MS is higher than in somebody with no relatives with MS. However, those children are much more likely not to get MS during their lifetime than they are to ever get MS. So that's really important. Their risk at most is around 2%, so around 2 in every 100 or 1 in every 50 children of someone with MS may go on to get MS in their lifetime. I think what's really important to know is we don't understand why this is. We think it's probably partly due to their genes, but not completely due to their genes. But also that environmental factors might play a role in increasing this risk. We don't understand a lot of these very well, and we're trying to do work at the moment to understand better what influences that risk.
Are any of the disease-modifying drugs safe to take whilst trying to conceive and during pregnancy?
So the first thing to say is that this is always done at an individual level, and if you're thinking about getting pregnant and having children, you should really speak to your neurologist or your MS nurse about this. The information that we have shows that interferon beta preparations, so Avonex, Rebif, Plegridy, are safe to take both whilst trying to conceive and during pregnancy. And also Copaxone, again in discussion with your neurologist, is probably safe during pregnancy. And these large molecules are likely to be safe during breastfeeding as well. For women with more active MS, the medication that's most likely to be safe or potentially used during pregnancy is Tysabri or natalizumab. There's increasing evidence around this, but really this is done on what we call a risk-benefit ratio, so weighing up the risk of discontinuing any medication to the person with MS, the risk of relapses or their disease coming back, versus any potential risk to the baby of continuing this medication. And those things have to be very carefully weighed up and at an individual level, which is why you've got to talk to your neurologist about this. We know that some drugs are really not safe to be taken whilst trying to conceive and during pregnancy. We know that fingolimod is not safe during pregnancy, and women should stop this at least a couple of months prior to trying to conceive. So it depends on what medication you're on, it depends on how active your MS is, so this is really something that is taken on a case-by-case basis.
With any of the drugs, do you have to have a kind of washout period before you start trying for a baby, and how do you know when to stop taking it?
Again, this is something to discuss with your neurologist. There's lots of information out there, some of it's quite complicated and depends on the drug and your MS. With some of the drugs there are very definite washout periods that you should adhere to prior to trying to conceive. The most important of these is fingolimod, where you should stop taking the drug at least a couple of months prior to trying to conceive. Other drugs where you need to think about washout periods are Aubagio or teriflunomide, and that's because that can sometimes have quite a long washout period depending on how you eliminate the drug or how you get rid of the drug from your system. So that's something to discuss nice and early with your neurologist. With the infusions, then they're a variable length of time, and it depends on your individual circumstances.
Is it safe for a man with MS to be on a DMD if he's trying for a baby with his partner?
There's almost no information about this out there, and I think this is a real area that's important to people with MS that the research community and the pharma community haven't really addressed. We know that small amounts of Aubagio or teriflunomide are detected in the seminal fluids, the fluid around the sperm of men with MS. And there have previously been concerns that this may be associated with a theoretical risk, although there's no real evidence to back that up. So I think the jury's still out on that one. The one where we think it is quite important is cladribine or Mavenclad. So with Mavenclad, both men and women should use adequate contraception whilst taking the drug and for some time afterwards, and men should make sure that they are adhering to this as well as women, because actually we know that it does interfere with sperm production.
I've heard that women with MS go into remission while pregnant and relapse after birth. Is that true? If so, why?
The first part of the question is, do women with MS go into remission during pregnancy? And the answer is yes, and we've seen this since the earliest studies, which were published in the 1990s, and we still see this in more modern studies that have been published within the last year. On average, women with MS have very few relapses during pregnancy, and the chance of you having a relapse gets less and less the further through pregnancy that you get. The reasons for this aren't particularly well understood, although what we do see is we see a similar pattern in other diseases of the immune system where the immune system is fighting against the body. We think that this happens because when you're pregnant, your immune system in general is slightly lowered, and it's as a way of trying to protect the baby from the mother's immune system. And probably this is what's having the effect on the MS as well. So thinking about after the baby's born and the risk of relapse after the baby's born, the earliest studies in the 1990s showed that there was a significantly increased risk of relapse in the 3 months after the baby's born, so the first 3 months postpartum. And again, you see this in more modern studies. So this is an effect where relapses go right down during pregnancy and then flare back up to above where they were pre-pregnancy after the baby's born. Again, this is thought to be due to the immune system sort of reactivating in the period postpartum.
What if I have a relapse when I'm pregnant? Will it harm my baby?
The most important thing to take from this question is that relapses do not harm your baby. Okay, so whilst relapses are horrible things to have and they can, cause problems for the mum, they actually don't harm the baby. There are treatments available for relapses, so we know that we can use steroids during pregnancy, and in fact steroids are used during pregnancy by obstetricians in late pregnancy, sometimes where the baby's at risk of being born early. We prefer to use the steroids later in pregnancy rather than earlier in pregnancy, and this is the same with many medications, because during the first 3 months of pregnancy, lots of important parts of the baby are being formed. That's not to say we definitely can't give them, but we prefer not to if we don't really need them. Okay. We also know that steroids, when used for the treatment of relapses, generally in MS, cause things to get better quicker, but they don't change how things are in the long term. And so using steroids to treat relapses in pregnancy is something that the mum and the neurologist have to talk about honestly, the risks and the benefits of both. And I think that depends on the severity of the relapse, how much it's affecting the mum, all of those kind of things, and really weighing up those risks and benefits at a really individual level.
What's the recommended dose of vitamin D for women with MS who are pregnant?
So there's no agreed guidelines for dose of vitamin D specific to MS when you're pregnant. So the Royal College of Obstetricians and Gynecologists has got UK-wide recommendations for vitamin D in pregnancy. So they recommend that all pregnant women should take at least 400 units of vitamin D a day, and those that are at high risk of deficiency should take 800 units of vitamin D a day. My personal view is that women with MS should at least be taking 800 units a day. The other important thing about vitamin D in pregnancy is when they've done trials in sort of looking at obstetric outcomes, so looking at things like preeclampsia, caesarean section, those kind of things, there's no evidence of harm to the mum or to the baby from much higher doses of vitamin D to be taken during pregnancy. We know that vitamin D might be important for the developing immune system of the baby, and I think this is something that's particularly important in women with MS. So what I would recommend patients to do, as long as they don't have any reason not to be taking high doses of vitamin D, then to be taking at least 800 units a day during pregnancy, and think about taking higher doses up to around 4,000 units, because we know they're safe, we know they don't do harm to the mum or the baby, and they might do some good in the long term.
Can a woman with MS breastfeed?
So absolutely a woman with MS can breastfeed. There's nothing about MS, sort of about the MS disease, that is a reason not to breastfeed. I think for some women with very highly active MS, there has to be an honest discussion with their neurologist around the pros and cons of breastfeeding versus restarting disease-modifying therapy. there is some evidence that breastfeeding may be very mildly protective against relapses in women with MS, but it's not as good as very highly active disease-modifying therapy. So this has to all be weighed up. We know that some of the medications are safe for use in breastfeeding, so particularly Copaxone, interferon beta preparations. And more recently, there's actually evidence that immune molecules like rituximab and potentially ocrelizumab actually don't get excreted into the breast milk in large doses. So these may well be safe for use in breastfeeding as well. So there is a discussion to be had there, and I think there's a lot of information that's coming out at the moment around this. So this is a field that's changing really very rapidly. So it has to be talked about, and it has to be talked about during pregnancy so that people know what their plan is.
What advice would you give to someone who's recently been diagnosed with MS but wants to start a family soon?
So I think I would take this on an individual basis. I'd take it person by person. I don't think there's any one-size-fits-all advice. It depends on how active your MS is, how many relapses you've had, how much disability you have, and also how advanced your family plans are. Are you sort of currently trying for a baby when you've been diagnosed? Is it something that you might want to do in the next 6 months? Is it something that's on the horizon the next couple of years? Because really all of those things will affect what you do. I think there is always a weighing up process between, well, do I delay disease modifying therapy and and continue to try for a family? And I think for some women that might be the right decision, especially those with less active MS, with relatively mild disease, who are currently trying for a family anyway. I think in people with more active disease, who maybe were thinking about starting to try for a baby in the next 6 months or so, it may be a better decision to start treatment and maybe aim for a period of MS stability for a few months before starting to try. So delaying things by a few months. So I really do think it's very individual, and it depends where you are in your life. And I think the discussion has to be around your personal situation and what's the best thing for you to do.